especially with dear friends that we have. And as Maurice was saying, like he did with Tawil, we try to do that with multiple patients, but it all started here from Dental XP, this culture of helping others and trying to get back into the world. So big thank you for that. And it's been a true honor to see him win the Most Important Amsterdam Award last year, and now this year with Howie. It's just such a pleasure to see our mentors just be there for us at every step of the way. So we really have to thank you for everything that you've done with us and for Dental XP.
So we're back in Hollywood. This is where all my fellow Jews come to retire to. And it's been a journey for me here many years out. How often I've been here, I truly do enjoy it coming back here, but especially when it's for a conference like this, where we can share our minds together. And after listening to Marco's presentation, I realized I don't really need to tell you anything. That was incredible. He really summed it up perfectly. So I'll add to a little bit to what he did, but that was a perfect lecture, and basically we think we're very like-minded, and I think a lot of us you'll see here are in that same boat. We are like-minded in the way we think. So hopefully maybe I'll give you a little bit of tidbits that may be different, show you a little cool technology as well. And let's start off by waking up with a little bit of a fun video. So this is basically incorporating everything that we do. Having the digital side with the surgical side. It's the perfect meeting for that, because at XP, that's what we strive for. To have type of technology that we can utilize, show different techniques like you saw yesterday that are mind-blowing, but also how can we use technology to help us along with that. So as a little disclaimer, you'll see some of these products. I'm a partner with a couple of these companies. I'm a consultant, I'm a clinical director for Shine 3D. And I work a lot with Megagen America, so when you see something and I say I like it, it might be because I invented it. So take that with a grain of salt. We have to realize that our calling card, our signature is our smile. And how someone's going to perceive us, how they're going to think about what we are going to look at in terms of our personality is very variable. We have 3 different smile types in literature. The Mona Lisa smile, someone who's not going to show their teeth. The social smile, that acquaintance that you see, that gives you a quick little buzz of a smile. Then the person who's very happy and excited to see you. That's a spontaneous, more complex smile. The more complex the smile, obviously the more detailed we need to be designing and keeping things in the correct positions. You look around Hollywood and you see some of these smiles all over. None of these are good quality smiles. Yet they fit their personalities, and they made them who they are. Some of these super famous people like Tom Cruise is a superstar with a midline 7 millimeters off to the left. This is the type of a calling card, their signature that they've worked with, and later on in their career they may redo their teeth. But till they got to the top, they didn't. And that's their calling card, that's their signature. When it comes to full arch prosthetics, we learned from the great late Carl Misch, brother of Craig, all the different prosthetic options we have for fix. And we should strive to go more for these FP1 type solutions. One thing that I hate to see, and I know many of us are fellow periodontists here, I'm not a periodontist, but there are many periodontists here, that really it breaks their heart when they see someone just chop off the mandible when it could have been saved, when they could have had a young patient with a really nice FP1 type of prosthetic. So that should be our goal to try to accomplish. And when we take that into consideration, we have to take a lot of aesthetic parameters to really think about how we're going to go ahead with this. So case acceptance is going to be the most important part of that. How we document the case, which will help us in our diagnosis and in our treatment planning. And from there, we're going to look at the macro and micro aesthetics. What type of aerial view are we looking at? How is the midline, as Marco just said, midline off on the case? How is the canting? Are we keeping the vertical dimension? Is there enough lift support for this patient? So do I need to go to FP2 or 3 restoration to push that out a little bit more? And the phonetics, obviously. Then the micro aesthetics. We care about the smile line, the shape, color, and texture of the teeth, and also the symmetry of the teeth. So where there are problems, there are always solutions. And we have to try to find those solutions. One of the problems is in the data collection and that communication to whoever is handling the case. Whether you're a super dental lab where you can do everything like Marco on his own, or whether you're sending it out to someone like Marco to actually help you make your teeth, they need the right communicational tools to help them. They don't have, as you know, your patient in their chair. The best thing would be is if you could literally send your patient to that laboratory. The laboratory could be states away. It could be continents away in many cases. So how we're going to communicate our lab and give them enough technology will help us in both our surgical planning, but also in our pre-plan for our surgical templates. How those teeth are going to look before we ever take the scalpel to the tissue. So what about the face? The face has been the biggest problem. We have to do an aesthetic analysis to figure out the componentry of the face and how that symmetry is going to be. Does the patient already have some discrepancies that we can capture? So when we look at facial analysis, the shape of the teeth to the ellipse, the phonetics, and then of course the micro part of that dental analysis, the color, texture, size. What are we looking to change for this patient to hopefully change their lives? 2D photography has been an amazing adjunctive tool to our armamentarium, and we are not doing away with it anytime soon. It is here to stay because it gives us amazing features that we can capture. We can see facial measurements, we can put simulation rulers in, we can do digital smile designs as the Coachman type of philosophy. We can do digital oral designs from other companies that are out there to try to get a better case acceptance, but ultimately so that the outcome will be what we are trying to accomplish, that the outcome matches our pre-plan. So when we break up the face into thirds, we look at the upper portion, we look at the middle portion and the lower portion. We can extrapolate all that information to try to figure out what may be discrepancies inside from a two-dimensional photo. But again, this is a two-dimensional photo. So the midline obviously is going to be the number one thing that is off. As Marco just said, on Facebook, there's always going to be midline discrepancies. And so how are we going to compensate for that? We have to try to capture it initially and then translate it over to the lab if there is already a midline discrepancy. So that facial midline becomes the first step to trying to analyze how we're going to correct this patient or how we're going to keep it. The facial flow, the symmetry between both sides of the face. In one study, it showed over 75% of the face is not symmetrical. That means everybody is misshapen, and that's the reality. And this is what we do. It could have been how the way they were born, it could have been from an accident, and they had some reconstruction. It makes no difference. We can't expect everything to be symmetrical, but yet we want the teeth symmetrical. And that's the interesting part of the equation. Your face is not symmetry, but we're going to make your teeth symmetrical. So sometimes a little imperfection might be an actual win and not have to have everything completely symmetrical. Trying to capture these angles in a cephalometric type of a capture with a two-dimensional photography to give us our occlusal plane, our cancer, which is our tragus, our Frankfurt horizontal plane, and we can get this in two-dimensional photography at a pretty decent ratio. But can we get it to the way we can using a different type of technology? That would be the ultimate goal, to be able to get that three-dimensional technology to that patient. We have different facial shapes. Again, this is perception. You see someone walk into the room and they may have a rounder face and appear more heavy. You may see someone who looks a little disgruntled and feel a little bit more about their personality, maybe slightly unpleasant. And this is taken from not from dentistry, from psychology, from facial analysis, and they use this in plastic surgery. This is what they're accounting for. So our perception is completely subjective. What one person might think is an unpleasant, to someone else who may know that person might think, oh, they're having a great day. They actually have a little bit of a smile going today. Normally, they have zero smile. And sometimes people don't want to show their teeth. We call those patients dental cripples. And they're constantly covering their mouths to hide their smile. That's the worst thing that we can have for our patients. We want them always to be able to smile, to enjoy life. Because they want, when they interact with other people, that's going to be a subjective response. They're not smiling, they're not happy. They don't like me. Something is off here. It creates some tension. So there are different facial shapes and there are different dental shapes. And whether you have a small face, a thin face, whether your teeth are in different type of shape is going to also relate to somebody how they perceive you because of this subjective type of appearance, of a feeling. So the same person with a mock-up with different shapes of teeth will end up leading towards a different type of facial personality. As you can see on the left, the smile is one way, whereas you go to the right and you go to more triangular, completely different person. Doesn't look like the same person. And that's the problem with the matching of the two between the facial shapes and the dental shapes. So the Cochrane group came up with this term, visagism, which is basically gives the possibility to the patient to express a different type of emotion, different type of personality trait, and that's all based off of their smile, based off their digital smile design initially. And in this, they went over these types of shapes and they assigned different types of expressive type of subjective feelings when you see those type of teeth. So an oval type of a shape will give someone more of a melancholy type of look, where a square type of patient, that might be someone who's more of a pacifist or a mystic, and it's a very subjective type of appearance based off of someone's tooth shape. And that's an interesting concept that you brought in. This is morphopsychology. This is not the standard of what we were always thinking about. We're just thinking, let's make them straight teeth. Let's give them Invisalign and move things over. But when it comes to remaking someone smile, it becomes imperative to try to encounter both the facial symmetry and the dental symmetry. So that by having more dominant centrals, we're going to have someone who might be a little bit more of an aggressive person. Or I might have more square person, might have more of someone looks like a blind that may be a little bit more hypertensive. So these are the type of thoughts that we have to consider based off the personality trait of the patient that presents to us. Because we don't want to give a happy-go-lucky person a Bruxer type of look, a flat look. They need more of a rounder type of look. And you can go into the male, female, he, she, whatever you want to call pronouns these days, makes no difference. How they're going to appear to others might be determined not just by their face, but by their dental shapes. So can we capture all these details with 2D photography alone? It gives us a tremendous amount of information, but does it give us the entire picture? So when we look at the American Board of Orthodontics, they have some errors with 2D photography, and it's mostly human errors. It's not the camera did something wrong. Could be. Maybe you set the ISO wrong. Maybe you had the focal distance a little bit off. But its reality is that we're human, and we're trying to do the best we can in taking our photography. So one big thing is removing a backdrop. I see so many pictures of patients in a chair taking a picture with a smile, and there's dental instruments in the background, there's cabinetry, and it's not exactly the right environment. We have a photo studio, but if you're like me in New York, a photo studio is a closet. So we have to do what we can with how much space we can work with. But having backgrounds, having distance between the patient and operator too much might eschew certain details that we may not be able to capture. Lighting is an issue. The most important thing is that at the bottom here is that the last part, that the camera is going to give us unreliable measurements. This is not an 100% accurate way. And I'm not saying that there is something 100% accurate out there, but there is certainly better than what we are working with now when it comes to two-dimensional photography. So here's a patient, you see one shoulder shrugging. Terrible picture. Can't really see, he's got a triple chin. I can't delineate facial type of appearances from that. Too much flash and washing out the light. How much are you going to play with Photoshop to try to get that to look correct? Some patients can't open their eyes. You know, some people are just don't understand how to stand. I'm one of those people. I'm constantly tilting my head up when I take a picture. Soon, I'm standing normal. Someone comes over to take a picture for a group picture, and my head goes up. It's just instinctive. And then there's what we like to call the dental cripple, that is unable to smile. It's been so long since they last smiled, they don't know how to do it anymore. They're constantly covering their faces around their friends. They go to a wedding and they end up not being able to smile and enjoy the wedding and have those magnificent photos that they're truly desiring. They may have paid a photographer for their daughter's wedding, like this woman over here, and this is the smile that she's going to give at her daughter's wedding. No, she's going to give a Mona Lisa smile, a smile with no teeth. And that's basically a dental cripple. So what can we do? We live in a three-dimensional world. Can we utilize 3D technology to help us to get the way there? Homer Simpson lives in a two-dimensional world, and in one episode, they turned into 3D. This is the new world we live in, with amazing gaming arcade technology that puts the glasses on, VR glasses. We have, the Apple Vision. We have Oculus. We have Microsoft HoloLens, amazing three-dimensional technology that is interactive. And when we look at our own objects with our own eyes, we can be fooled. What is 3D and what is 2D? And this is because it's how we perceive the object in advance. We automatically assumed that Rubik's Cube was in 3 dimensions. And we may have thought that that little representation of Buddha was flat, but it was actually in 3D. So this is the type of things that we have to deal with because our eyes always want to play tricks on us, which reminds me of a great movie.
Don't trust them. See? You can do it. I call it luck. In my experience, there's no such thing as luck.
So his eyes can deceive you. So he put his blinders on him to let him get a feel. And this is how we have to be with our patients. We've got to get a feel of how they are. What are we looking for? How can I help you? It's not just about how much can you afford. And I'll give you FP1 if you pay this much, FP3 for this much, FP5 for that much. That's not the RP5 for that much. That's not how we operate. We need to get a sense of what that patient is looking for. We want to capture it. And then the last line that he said, there's no such thing as luck. Right? He's a Jedi. He believes in the Force. But I agree with him. And Thomas Jefferson, you may like him, not like him for the past, but he made some amazing statements while he was young, 33 years old, trying to help us in this country to make it a better place. And one of the things that he said is that he was a great believer in luck. I believe in that too. I'm a great believer in luck. But as they say, luck is what you make of it. With hard work, you're going to get luckier. The harder work you put in, and the more devotion that you have to that case, the more luck you're going to get out of that case. It's just the way it works. We put in what we get out. We get out what we put in. And if we put in more, we get back more. So what tools can we utilize to help us? When you're building a house, you don't just look at two-dimensional plans anymore. These days you get full-out CAD designs. They can put a simulation of you in your bathtub, taking a bath or a shower. That's how amazing the technology is. With AI, it's getting even more impressive. We have facial scanning that is out now on our phones. Everybody has this. There's amazing technology to do filters to make someone who looks 80 years old, 20 years old. You can't trust half the things you see online these days because they could be altered through AI. This is the world we live in. So how can we utilize some of this to give to our patients back a little bit more? And so I'll start by this. I had a patient that came in and saw us at one point in time to try to complete a procedure, and she ended up going somewhere else because we were too expensive. And so she came back to us about a year and a half later like this. She had done some bridge work. She has 2 out of the 4 implants left, and one's hanging by a thread. So I have unstable records. I can't really get an accurate record. And she's going to get married for her 3rd time. 3rd time usually means they have divorce money. So now they're ready to pay. Before she couldn't afford it. But after 2 divorces, And now another husband, now all of a sudden she can afford my bill, which is really not that expensive for New York. So we have to get some stable records. And she's getting married. So let's get into something quick. You saw Marco, what he showed on the guide and all that. That's basically exactly what we did. So we did for her FP3 on top, and we tried to go FP1 on the lower because we could, and we don't have to increase our vertical dimension, which we tried to capture. It wasn't ideal, but at least we got a stable provision. And from there, we can start to break out our digital instructing instruments. And in this case, one of our first things that we wanted here was to get an actual facial scan besides our two-dimensional photograph, so we can then incorporate that and all the details that comes along with facial scanning. We can do the eye jig as he just showed, which is the reverse scan analogs. But when we capture the eye jig and the tissue, we can put all this together into the software, and now we can get some numerical values that can help us translate over and communicate to our laboratory literal details by numbers. Are these 100%? Maybe not. Maybe they're only 96%. But that 96 is better than that 50, 60% maximum that I might be able to get out of a two-dimensional photography. So being able to look at ala tragus, being able to look at Frankfurt horizontal, look at all the different dental shapes, look at the midline. These are attributes that we can have with our digital technology that we can then bring into softwares, such as a software like this in ExoCAD. And you can see what you see here with a 2D picture, but when we bring it into 3D world, and we can now extrapolate all that information that we brought in and put it together with the facial scan, we'll be able to not just design a new set of teeth, but we'll design a new set of teeth that we saw what was wrong with the old set of teeth, bring that together with the facial scan in the three-dimensional world, and now truly be able to say, now the midline is close. We are there. If we're not perfect, we are damn near close. Our teeth are not canted. All these factors to help us finish these cases faster in a more economical fashion. So we can easily go ahead and 3D print the restoration the same day once we have the file. In about 15 minutes or so, we can print the restoration or less with the newest printers. And we can take another 5 to 10 minutes to cure it, and we can try it into the patient's mouth and now try to be able to give her a temporary that she can have for her wedding. And now she was able to go ahead and get married properly. And we did all this in just a matter of a few weeks. And that's what we try to strive for. Now she's still in temporaries, and she's going to stay that way, unfortunately, until she pays the rest of her bill, and we'll just keep making more temporaries over and over for her before she gets her final teeth. But at least, maybe she's going on divorce number 3. Who knows what's happening at this point. But the goal is to try to be able to help our patients to move forward. And he was referred by the last patient. He was the hairdresser for the wedding. And he loved her teeth. So he came in, and we did the same type of workup for him. Obviously not for the wedding. We didn't care about that part. So we brought him in, we took some two-dimensional photos. We now also incorporated, at that point in time, not just the facial scan and intraoral scan into the software, but now we're able to bring in the actual CBCT so that everything is matching beautifully, which helps our digital designers. I don't know if to call them lab techs, because they're truly designers. It's a craftsmanship. It's an artistry. But we can give all that data over, along with the facial analysis, to the laboratory, and they will actually get a literal report. So if they're not very tech savvy for some reasons, and they want to just look at numbers or have it on the side, they can actually have a serious report of every single numerical value that is captured by the facial scanner. And you can even import your own scans at that point, your own measurements at that point. So we have, look at the smile line, we're going to design a stackable guide for him, which is I'm a big fan of the stackable guides, and he needs a nice solution, but I want to try to go FP1 whenever I can, and this is one of those cases. So we'll incorporate a lot of factors to try to get him the best teeth that we can by utilizing the technique, the scallop guide that was first discussed, and you'll see a little bit later, the paper by Dr. Salama, Posi, and Tadros, on that, and Wendy Clark on it as well. We were able to make a scallop guide for him as well if we wanted to, but we decided not to because we were in a bit of a rush. So we went straight ahead with our standard guide. We did this without raising the flap because we wanted to keep it in an FP1 solution, and we really did not want to lift the gingiva if I didn't have to. And then we went over, and of course TBS is my company, so I went over to my favorite instruments, to extract these teeth using minimally invasive extractive approach. There is no such thing as an atraumatic extraction. That word should be stricken from the dictionary. Atraumatic, when you're ripping someone's tooth out of the mouth, is nothing atraumatic about it. There's trauma, but we want to be able to use as little trauma as possible. For the canines, these are very important to me. I couldn't do partial extraction therapy on some of these teeth, but I could using Howie's kit. As you see on the bottom there, we were able to perform partial extraction therapy on the canines. And that's important to me because I want to try to keep that canine eminence for the overall facial symmetry. We've written many articles on it, on partial extraction therapy. And then I always throw this in just because I invented this push blade and I love to see nobody get hurt by a blade ever again. A simple ejectable blade, so you don't have to take it off with a hemostat. This is the Tawil push blade. I did put my name on it. Dan Holtzclaw may not be here, but I'm not embarrassed to put my name on my inventions. He is very humble. Maybe I'm not as humble. We go then toward the surgical guidance. We want to have a guided surgery solution, so we start preparing, and we use these burrs that I developed with Dr. Gary Brand called Universal Shapers to widen out the upper portion of the osteotomy to allow for a smooth, easy insertion of our multi-unit abutments, because we are going to go to MUA for passivity purposes when we're connecting all the implants together. And the goal of trying to scalp in these cases is not to do it after you place the implant. This is the reason we came up with this concept. Why are we drilling, placing the implant in, and then profiling? Shouldn't that all be done in advance? We're planning in advance. We're planning drills now. We are not planning implants. We're planning where the drills go. And we can look at the CBCT, get a good feeling on the density of the bone, and now we can shape the osteotomy first and then place the implant so we can get a proper emergence profile. And our goal should always be to stay away from the cortical bone with bone level implants. The cortical bone is the worst bone in the body. This is the bone that has zero vascularity. It's strong, but it has no blood supply. So our implant should be placed in the lower region where the cancellous bone is. You may have very minimal cortical bone, so you may not have to go very deep. But as a rule, we try to get deeper, and as you saw in Joseph Kahn's lecture yesterday, going 3-4 millimeters deeper is his protocol. My protocol is, where is the cortical bone? Where is the cancellous bone? How much space do I need for my prosthetic? That's my protocol. So when someone asks me, how deep do you place my implant? Well, what does my prosthetic look like? If you show me what my prosthetic's going to look like, I'll tell you how deep my implant is going to be. If you tell me what type of multi-unit abutment I'm going to use on a full arch case, if it's a 0 degree or a 30 degree, it's going to change my depth of position dramatically, because I'm going to go deeper with that 30 degree so I can correct for that angulation and hide it a little bit more, because they don't have the cuff heights. The 30 degree starts out at a taller cuff height. So I got to go deeper with that 30 degree multi-unit abutment. It's common sense. So it's never how deep do I place my implants, it's where is my prosthetic and how do I meet it? And how do I retain that emergence profile? Oh, sorry, there was a little slide there. So please go on to Dental XP and watch more about that lecture. We gave that last year at XP. The QR code was there. We then surface treat all our implants with plasma. We're finding amazing, faster ISQs, and we're going with even better loading with our plasma light. We always take ISQs, and you can see these really nice ISQs we get from the very nice nitrogen, more aggressive any-ridge implant, especially maxilla. They just get amazing numbers. And then we go ahead and we start to shape and scalp around the implant as well. Any areas that I didn't scalp enough, I'll go and fine-tune. I really want to make sure I'm creating enough seating using the shaper burrs, trying to get a little bit more. And this is, again, based off of the article from Maurice and from Ponce and Wendy and Marco about this scallop guide. You can do it free-handed, you can do it guided. I love to do it guided, but it does take a lot longer to plan these guides. But this is a great method. If you've never scalped before, I really encourage you, because this was a mind-blowing article to me. When I saw this, the first time that Maurice ever presented it, I was blown away. I know Ponce likes to do it with dynamic navigation, but he still does it. He's scalping and thinking about creating pontic sites, thinking about scalloping them, and being able to create interdental papilla, not just with the prosthetics, but also with our actual drills, so we can contour, like crown lengthening on cases. We then are going to lute together the structure in the mouth, and I'll skip the luting process, and now we have temporary cylinders that will go inside, and we'll just lute that, pick it up, and then we can screw it in. Obviously, we go over post-op instructions and function, but this is based off of our design. It's a prefabricated prosthesis, and he leaves it very nice teeth with temporary cylinders, and we treated the lower as well. He then comes back in, and again, why do we want PET, especially on the canines to me, is because this region over here, what's going to happen to that region if I extract a tooth? And then what's going to happen to that nasolabial folds in that area? It's going to become flat. So, at least for me, I need to save the canines. And so, to me, it's a lot easier to extract a tooth, but canines are not easy to extract. So if there's no problem with tooth, there's not fractured, I want to keep it. You saw Howie's lecture yesterday, we can have some complications, but they're minimal. They're minimal. After 15 years of doing this, we see such amazing success coming from partial extraction therapy, as you saw yesterday with Howie. And they've written some amazing articles. These are just a few, but we have to remember where it all started with. It started with Henry's first case of root submergence, and Maurice writing the article, and it's been moving forward ever since. And now, Howie told me yesterday, it's like 700 articles plus that are in some systematic reviews. That's incredible. Just amazing how many articles that there are going around. And not to mention, those are published journal articles. There's also magazine articles galore on this. That's incredible to think about how much that this technology has gone through, and that's a big thank you to Dental XP for taking us there. One negative about doing it this way. When we do these intraoral pickups, we run into some problems. It's a bloody surgery, and sometimes we can get blood caught inside, and maybe the bonding doesn't happen perfectly, and our prosthesis can fracture. So how can we fix this quickly? So nowadays, the new printers that we have, when I was treating him, we were using a printer that was slightly a little bit slower, but now we can print so quickly that we're able to get him some new teeth very quickly. We took a tissue scan, we took the temps, we did the reverse scan of the broken temps, which I'll show you in a moment, occlusion, facial scan, and now we send over that report to our laboratory. Let's fix the canting that we got, because during the day of surgery, our guide was a little bit tilted, and so we had a little bit of a cant. Let's fix the midline, we're off by 0.5 millimeter, as Marco told you just a moment ago, seeing a millimeter or two off. So we could utilize photogrammetry to capture, but the problem with photogrammetry, although I love it, if you can afford it, it's amazing, is that it's a little bit pricey. So other companies are out there that are trying to bring the price down, but it's still an expensive tool. And it's not something that necessarily every dentist can afford. We wrote an article about this last year called Fully Digital Full Arch, and it goes over these different concepts of other tools that you can utilize, in which we speak about the OptiSlim, about being able to loop together scan bodies. But even that was a little bit pricey, and it's not necessarily for every case. So we were working on trying to find a new solution, and so we came up with a solution called the Arch Bridge. The Arch Bridge is 8 unique shaped scan bodies. They're textured, they help us with move forward with a in-contact type of approach where we're going to have the scan bodies touching each other, but they can have a little bit of a gap if we want. We want to get as close together as possible. They're textured so they're non-reflective for the scanner-like technology, and you get uninterrupted, unimpeded full arch scan. So utilizing this arch bridge type concept, you can see how we placed it here. We skipped the photogrammetry even though we have it in our office because we're trying to keep validating, and we're getting down to about 10 micron accuracy with this, which is really incredible for an intraoral scanner. And we have some more amazing stuff coming in July that's going to be incredible. This article will be published in Inside Dentistry in 2024, later this year in June, and please look out for it. It's going to explain all the details of how we're utilizing this. But it gives us an unimpeded, uninterrupted scan, and that's what we're looking for. So that the scanner doesn't get confused. It doesn't see one scan body on the other side, and then the AI comes in and thinks it's a scan body on the left side. And that's the biggest problem with scanning, that we get these uninterrupted, we get these interrupted scans. So we did repair that little prosthesis, but it broke again when I took it out of the mouth trying to do the reverse scan technique, that IG technique. So I just popped into the desktop scanner, I kind of meshed it together with my hands, so I can kind of get a nice, decent look of what the intabular surface is and where the temporaries actually are. you can use an intraoral scanner, but if you have a desktop scanner, there's nothing more accurate on the planet than a desktop scanner. So we capture that, and we can now see the relationship of those teeth to the tissues and to the implant or multi-unit abutment. And then we can start to duplicate that. We can send it over to a lab, and within 20 minutes, so that I can get a new design, start printing. You can see this print happening very fast. It's 16 minutes that we get the print. It's really incredible how fast we can print. And if I want to print a little bit less microns, at 150, I can print this in 10 minutes. Then we got to go through the wash and cure. There's a very nice unit out there that we worked on developing to help us cut the model off of the actual base plate, so it just gets transferred over, so it's a mess-free. Because we're not laboratory techs, we're not looking to get dirty with lab stuff. We want things to be nice and clean and easy and simple to transfer. So now we have a really nice set of FP1 teeth that doesn't have temporary cylinders inside. We can glaze that, we can cure that, and deliver not a broken prosthesis that's repaired, but within an hour, a brand new prosthesis that has really nice anatomy instead of having a flat type of a plane. And again, that was a 16-minute print. Since then, I can make them even faster. So now, he leaves, Robin leaves with a nice set of FP1 temps that look very nice. We're starting to work on certain features now, different shapes, and we can insert that same day. We get a nice good passive fit there. In this case, we did use the vortex screw. I'm very intrigued by Marco's new screw. I'm very anxious actually to give that a try because I thought I knew every screw until now. So this is how we left that day. He came back in, and now it's time to make his finals. So in a very quick method, we're going to go ahead and just duplicate that, maybe make some minor changes, which we wanted a more square type of look to fit his face. And now he is a very happy camper. And now he's referring us patients as well. So we're basically changing lives one smile at a time. It's a little phrase that I've been saying for many years, and that's our goal, to try to deliver the ultimate smile for our patients and to change their lives, either one arch at a time, or dual arch at a time, or one tooth at a time. But our goal is to help them to achieve what they're looking for. So, it's funny you should ask about why not do this surgery in the same day instead of having all these fancy guides. And yes, we can do that as well. We have Merced here. He came in and he was referred by his mother, who actually was a patient of mine. And he was looking to get a rehabilitation. So we imported his CBCT into the software, along with the facial scan, and merged everything together, including the intraoral data, so you can have that CBCT aligned very nicely, submit all that information in one file over to the lab instead of in 6 or 7 files over, which makes for easy data transfer. And of course, we can get the facial measurements and capture those. We can then bring them into a planning software, and there are many planning softwares out there. But what's fun about the planning software is you can even give these guys some nice cool shades. You can do some virtual segmentation. We can then go ahead and start to plan our design, how the teeth are going to look, where the implants are going to go. And we can see where those screw access holes and where we have to bring the teeth to. So we import that intraoral scans, we are able to make our surgical guides, and we are able to move forward. Again, with minimally traumatic extractions, but this time, we're not going to take out all the teeth. We're only going to take out a few teeth, and we're going to keep a couple so that we can do an easy matching post-surgical. So we'll take out just a few teeth that need to come out, where some implants are going to go, and we're going to leave, in this case, 3 teeth. We're going to keep these 3 teeth and open up the flap, always trying to open up to increase that soft tissue and thickness to help get better preservation. And now we'll place a standard surgical guide, which I can make in a couple of days. So instead of waiting a month for an entire prosthesis to get made with teeth, I can have a patient come in on a Monday. By Wednesday, I can do the surgery. I already have the plan, and the teeth can be delivered the same day. That's a big case acceptance feature. So we start out with surgical guidance using the blue diamond implant here from Megagen, the fantastic implant, actually my favorite implant now. And then we start to incorporate from Dynamic Abundance their surgical kit for maximal irrigation. They have cuts in this region here that allow us to allow water to come through, so we get less heating, or no heating. And then of course I'm going to use the shapers to scalp and sculpt the upper portion of that osteotomy so that we can have a nice emergence profile. So again, I'm using a lot of kits here. I know it seems a little daunting, but to do quality surgery, you need quality instrumentation. And you can't cheap out on your patients when it comes to trying for a stride function. So we'll make several osteotomies. We'll bring in the shaper burrs to try to open up that region and allow the multi units to sit. We're fully guided with some of the implants, but we had some difficulty with one of the extraction. So we placed one of them freehand. And that's a big attribute to not being committed to that prefabricated structure, because now I can move my implants more posteriorly if I desire to. When I have them in the perfect position, they will line up in the perfect position. But when I have to augment, have to audible day of surgery, it's not a concern. We can move things over. We can continue to scalp and shape the osteotomies using these diamond burrs to help open them up and allow for those multi units to seat. We'll do that on all the implants, and we can even do it into the pontic sites as well to continue to scalp along. And eventually, we have now a nice placement of our multi-unit abutments. Then we bring the arch ridge into place, and this is where it becomes really important. Scanning in a bloody mess. Can you scan or scan in a bloody field? Because that's where the biggest discrepancy is. Well, if I have connected scan bodies that are close enough to each other, I'm going to have an uninterrupted scan. And if my scanner can scan color really well, and not the AI doesn't have to be tricked, but if I can get a scan completely like so, where I'm scanning even in blood, everything, without any concern, now I have an actual capture that I can go ahead and match to my final plan, to my prefabricated plan. So we're keeping 3 teeth. We have a triad of teeth. Now we can then translate over into that model world and go ahead and finish our design. When we don't have teeth, we can use fiducial markers to be able to go ahead and match in that same motion and still maintain a triad of teeth. So to drive home the point now, we're taking out these teeth and using our colorless solution. We're using PRF and dentin grafting. In that site where we had that big defect, no harm from foul, we're able to just do some packing and some bone grafting and be able to utilize the amazing technologies that are out there to help us. And now we can scan, even in that bloody mess, the healing abutments quite nicely for the digital matching of that scan to the actual prefabricated plan. And this is the secret. Keeping these triad of teeth until you're ready to take them out, having something that will line up to match easily for the designer will take your turnaround time down. So instead of a 1-hour turnaround time, we could look at a 20-minute turnaround time. And then with just a 15-minute print, wash, and cure, we can have a really nice set of FP1 teeth. In this case, it was 15 minutes and 12 seconds to print and deliver a nice set of temporary teeth that fit very nicely utilizing the Vortex screw system. And this is how we left that day. With a nice FP1 solution that's done very, very quickly. Comes back, we scan his teeth very nicely, we do the iJig process, and we're going to finalize him in a new type of a structure called nanographene, Graphene Nano. It's a really impressive material that we've been experimenting with, and we're getting some really nice results by finalizing these cases, utilizing the facial scanner to get our actual dimensions perfectly and deliver a very nice final that actually radiographically barely shows up. You'll see here on the final x-ray, it looks like a PMMA and it feels like a PMMA. It's light and beautiful aesthetics. So he's got a great smile now. He's very happy about his teeth and he's moving forward with his life. So if I can just do a couple of take-home points that we've got out of that, I'm not kicked off yet because I am over time and I apologize. If there's a couple of take-home points that we can deliver from this, is that when we're going from prefabricated to post-fabricated, we have to think about the prosthetic choice. FP1, 2, 3. What are we going to use here? Fabrication time to make that appliance. Is it going to take me a month to get the prosthesis, or can I do it in a couple of days? How long is that surgery? Now my surgeries are shortened dramatically because I'm not replacing these type of guides anymore that require necessarily full flaps for the whole entire joint. Am I committed to my implant placement, or can I make audibles and augment same day of surgery? The quality of the temp. Am I going to have those metal temporary cylinders and worry about things breaking? Or can I have something that I can do, make reproducible temps? I can make several backups of these. I can print 8 copies for like $5. That's cheap. Once it fits, we can keep going and make more, and that will increase our case acceptance because we have a much nicer temporary solution. So it gives us, when we talk about that macro, micro, and the case acceptance, it gives us all of that data, so it's no longer a problem, it becomes a solution. And once we have solutions, utilizing the right technology, one more slide. Once we have all that solutions with the right instrumentation, we can make change possible. It's not just possible, but it should be expected.
And we can then go ahead and be dreamers in our own world, utilizing the technology to become better at what we're trying to accomplish. And that to me is the true digital revolution. Thank you, and sorry for